Good evening, everyone. Welcome to our symposium tonight. My name is John Pursley. I am one of the Chief Assistant District Attorneys in the Cobb County District Attorney's Office. My Co-Chief Assistant District Attorney is back in the back, Cindy Yeager. We have a few others from our office. I'm not going to try to hit everybody, but Kim McCoy is our Director of our Victim Services and Grant Writer Extraordinaire. Dr. Baldwin and I were talking about that just earlier this evening. You'll hear from Sanjetta Tillerson tonight, and from Aaron Boobens, who is our investigator. He's here somewhere, our grant investigator. There you are. Hey, Aaron. I bring you greetings from our elected district attorney, Flynn D. Brody Jr. He could not be here tonight, and he is sorry for that, but he asked me to come in and get this started tonight. We have a great program for you. We want to welcome you to the inaugural Cobb District Attorney's Cobb County Opioid Symposium. This is sponsored by a 36-month grant that was awarded to us in March of 2019 by the Bureau of Justice Administration. The grant was renewed just recently for another 3 years, so that's fantastic news. Our objective is to combat the opioid epidemic in Cobb County through convening a multi-agency, interdisciplinary, collaborative group of key stakeholders. We continue to work through fatality reviews, case management, and investigations. You'll hear about all of that tonight. Additionally, we will prioritize a comprehensive and community-focused approach to the opioid epidemic through partnerships with the Davis Direction Foundation, Cobb Douglas Public Health, and many others. I'd like to acknowledge and thank our stakeholders in this endeavor, many of whom you will hear from tonight. This is a long list, and it's hopefully comprehensive, but it may not be. But I'm going to read it nonetheless. So, most, if not all, of our stakeholders are the Cobb County Board of Commissioners, the Cobb County Magistrate Court, Cobb County Superior Court, obviously the District Attorney's Office, Cobb County Juvenile Court, the Department of Public Health, Highland Rivers, which was formerly the Cobb CSB, the Ridgeview Institute, the Zone, Davis Direction Foundation, the Extension, Metro Atlanta Ambulance Services, Puckett EMS, Wellstar, Cobb County Fire Department, the Cobb County Medical Examiner's Office, our police agencies, including Cobb County Police Department, Marietta Police Department, Ackworth PD, Smyrna PD, Kennesaw PD, Powder Springs PD, and the Kennesaw State University Police Department, the Department of Community Supervision, and the Cobb County Sheriff's Office, as well as the Division of Family and Children's Services. So that's a lot of folks. Many of y'all are here tonight. Hopefully I got most of you. I don't know. We'll see. I was supposed to talk about any elected officials that might be here. State Senator Kay Kirkpatrick is here. Kay is going to be speaking to us in a little while. And who we have, our chairwoman. Is that our chairwoman? I can't see that far. Sorry. Even though it's so much lighter in here and it's fantastic, I can't really see that far. And we have several other familiar faces here, and we're glad to see so many people out with us today. Finally, thank you to the Cobb County Communications Department for their support for streaming our program tonight. And once again, thank you to all of you for being here and any of you watching online. And thank you for wanting to learn more about this important issue for our community.
Thank you, Jane. Thank you, Mr. Pursley. Good evening and welcome. On today's agenda, we will hear from Senior Researcher Dr. Kevin Baldwin with Applied Research Services, Overdose Prevention and Response Specialist Lori Jody with Cobb and Douglas Public Health, Division Chief Nick Adams with Cobb Fire and Emergency Services, Opioid Fatality Project Case Manager and Investigator Sanjetta Tiller and Aaron Boobens with Cobb District Attorney, members of the Davis Direction Foundation, known as the Zone, Program Director and Fundraiser Coordinator Daniel Spinney and Sarah Mangold. For closing remarks, we will hear from Senator Kay Kirkpatrick, State Senator for District 32. At the end of the presentation, we will answer any questions from the audience. If you need an index card to write your question, please raise your hand and someone from our office will be happy to provide you with one. Now I'd like to welcome Senior Researcher Dr. Baldwin.
Thank you, Sanjetta, and thank you for all who are here and for those who are watching online. We're here to talk about a really difficult topic tonight. We're talking about overdose fatalities. We're talking about it because I don't think we can not talk about it, and that's because it's such a huge issue. So we're going to tonight start by going over some numbers. We're going to start with a national perspective, then we're going to hone in on the opioid crisis in Georgia, and then we're going to get even more specific and talk about Cobb County, because that's where we are and that's where we work, and that's really what these efforts are focused on addressing. The first thing I want to do, though, is draw your attention to this video. This is a video that was put together by an outfit called the Data Boys, and what it does is it shows different types of drugs and the number of people that have died cumulatively from overdosing on these different drugs, beginning in 1999 and working through 2020. So pay attention to this. Also, listen to the music and see if you can recognize the artist that's singing the song.
Good news, good news, good news, that's all they wanna hear. No, they don't like you when I'm down. But when I'm flying, no, it make them so uncomfortable, so different. What's the difference? When it ain't that bad, it could always be worse. I'm running out of gas, hardly anything left. Hope I make it home from work. But so tired of being so tired. Well, I gotta build something beautiful just to go set it on fire.
It's about a minute and a half long, but it tells an amazing story, an amazingly tragic story, in particular about the rise of fentanyl. But if you look at those numbers, those are huge numbers. Those are the cumulative number of people that have died from those various drugs over the last few years. So let's get a better sense of what those numbers are. The CDC right here in town keeps track of this stuff, and our state Department of Public Health does as well. But let's start with a national perspective. The CDC indicated that in 2021, just under 108,000 people died in the United States of drug overdoses. That's the largest ever number of people that have died of drug overdoses in any 12-month period ever. Just to get a sense of what that number represents, if you took Sanford Stadium, which is where the reigning national champion Georgia Bulldogs football team plays, and you added to that McCamish Pavilion, which is the Georgia Tech basketball stadium, if you added the total capacity of those two stadiums, you'd still have 7,000 people who couldn't find a seat. And that's just the number of people who died in 2021. If you've ever been to that stadium, Sanford Stadium, and looked around and seen all those people, that's a lot of people. So we're talking about some huge numbers. It's a 15% year-over-year increase. Now, if there's any silver lining whatsoever in this cloud, it's that that rate of increase has slowed, and that the rate of increase from 2019 to 2020 was 30%. So hopefully, the numbers are slowing down, but they're still increasing, right? Which is a huge problem. Overdose deaths from opioids, and that's our focus here tonight. And that's the focus of our grant-supported work here in Cobb County. Went from about 70,000 to 80,000, an increase of 10,000 just from opioids in a single year. And opioid deaths from synthetic opioids, most commonly fentanyl, have skyrocketed. But it's been joined by an increase in deaths from overdosing on cocaine and methamphetamine, and we're going to talk about that a little bit later. So we're seeing rises, increases in overdose deaths, not just due to fentanyl, not just due to opioids, but also because other drugs are being adulterated with fentanyl. Drug overdose deaths have become the leading injury-related cause of death in the United States, surpassing automobile accidents, exceeding accidents due to firearms, and for the first time in 100 years since World War I, contributing to a decline in our life expectancy. So if you think, oh, I don't use these drugs, they don't impact me, they don't impact my community, well, they impact all of us. When our life expectancy is decreasing because so many people are dying of drug overdoses, that's a huge issue. That's a community issue. Let's look at Georgia now. Let's hone in on Georgia. A little over 2,000 people died of a drug overdose in Georgia in the 12-month period ending in April of 2021. That's a 36% increase over the same period a year before. That's a higher increase than that we've seen nationally, which is about 28 or 29%. So Georgia, thankfully, is not among the top tier in terms of rate of overdose deaths or even number of overdose deaths. Unfortunately, those states, West Virginia, Kentucky, Pennsylvania, Maryland, Delaware, all up in that Rust Belt area, we're not there, but our rate of growth is increasingly problematic. It's increasing at a greater rate than the national rate in terms of overdose deaths. Looking closer at Georgia, we look at our own public health system here in Georgia. They have an excellent system called OASIS that you can get to on the web, and you can look at county-by-county numbers from opioid, fentanyl, other sorts of overdose deaths. And what we're finding is that overdose deaths have increased substantially right here in Georgia. In fact, they've increased 56% from 2019 to 2021. Those deaths involving fentanyl, which is a synthetic opioid, have increased at a much higher rate, 218% in that same period. Now, you might have heard about the opioid settlement, the multi-state opioid settlement. Georgia's been a part of that. We stand to benefit from that by getting about $636 million in the state to address treatment and prevention efforts. So that's a good thing, but it's a very difficult issue to address. Here are some graphics that depict the issue here in Cobb County. Now, this first graphic shows three different lines. The first line, the top line, which is in blue, is the total number of overdose deaths. The middle line is opioid-related. That's the red line. And the bottom line, the green line, is fentanyl-related. Now, you can see that beginning in about 2017, the overdose numbers started to decline. When did they go back up? At the pandemic, exactly. The numbers went back up in the pandemic sharply, not just here in Georgia. Over 40 states registered huge numbers in terms of increases of deaths due to opioids. One of the scary things about opioids, the high associated with taking an opioid gives you a sense of well-being. It's been described by addicts, by persons who have opioid use disorder, it's been described as a feeling of being loved. When you're stuck in your house, when you can't go to treatment, when you can't go to your meetings, when you can't see anybody except on a tiny little square on your computer screen, feeling loved is pretty attractive, right? So we saw huge spikes. Let's look at this next graphic. This next graphic talks about fentanyl and the huge rise in fentanyl. The top line, the green line, those are all opioid deaths. And this timeline starts in 2010. So it starts a little earlier than the previous graphic, right? So in 2010, you can see those numbers were pretty low for a few years, and then they started to go up in 2013. Some of you are quite familiar with the advent of prescription opioid pain relievers, or OPRs, like OxyContin, oxycodone, and how those are being marketed. That's why we have the multi-state opioid settlement, right? So you can see the numbers going up precipitously. You can also see the blue line, those are heroin deaths. When people couldn't access prescription opioids and started getting heroin because it was cheaper and more readily available after the passage of prescription drug monitoring laws in all but one state in the United States. Fentanyl is the red line. You can see in 2019, fentanyl and heroin diverged. The fentanyl line shoots straight up. The heroin line actually went down. So we've had a decrease in heroin deaths in the last year or two, but we've had a massive increase in fentanyl-related deaths. So we actually now have a fentanyl crisis. It's not just an opioid crisis, it's a fentanyl crisis. It's not just here in Georgia. It's not just here in Cobb County. It's nationwide. You've probably seen it on the news, but it's very pronounced locally. You may have seen just a couple days ago, a Kennesaw man was found to be sleeping in his pickup truck behind a closed gas station in Florida. Alert policing went back, asked him why he was there. They found he had a fanny pack with enough fentanyl doses to kill 170,000 people. And that amount of fentanyl weighed less than a pound. If you don't have tolerance, if you haven't built up tolerance for your opioids, all it takes is a couple milligrams of fentanyl to be a fatal dose, right? So fentanyl is finding its way into so many other drugs of abuse because it's potent, it's relatively easy to manufacture, it's flooding the United States from south of the border and from China. Because it's so potent, it doesn't have to be transported in the back of a semi. You can have enough doses in a fanny pack to kill 170,000 people. So that's why it's proliferating. And a huge issue with fentanyl is it's being put in what are called pressed pills. About 40% of black market fake prescription pills contain a lethal dose of fentanyl. People don't know what they're taking. In Gwinnett County, which is where I live, back in July, there were 40 overdoses in a 17-day period in July. They were not all deadly. But Gwinnett County's seen about 100 overdose deaths already this year, most of them due to opioids. And what was going on is that these pressed pills, which masquerade as Percocets or OxyContin or other legitimate prescription drugs, they're being sold as such. They're being sold as if they were diverted from the legal market, but they're not. They're pressed pills, and you're really rolling the dice when upwards of 40% contain a lethal dose of fentanyl, right? So this is a huge issue. It's deadly. So what has Cobb County done? As Assistant DA, Chief DA personally just indicated, Cobb County received 2 grants, 2 COSAP grants. That's kind of an acronym, but basically what it means is grants to address persons with substance use disorder. The first one was received in 2018, or at least awarded in 2018. The second one awarded in 2021. Frankly, it's rare that a community will get a continuation grant, so I've got to take my hat off to the DA's office, and in particular to Kim, the grant writer who wrote those grants, because what's happened is that the pandemic, just like it disrupted everything else, it disrupted somewhat the work we're trying to do here, but it didn't stop the work, right? So the work had 3 focal points, basically. The first was to establish what's called an opioid fatality review panel. This panel, which is headed up by Sanjeta Tiller, who was just up here a minute ago, and you'll hear more from her later. What they do is it involves a lot of stakeholders from around the county who get together and they study in depth the life of someone who unfortunately passed due to a drug overdose. Sanjeta interviews family. We talk with the medical examiner's office, medical providers, healthcare providers, community supervision, police, the courts, and we find out as much as we can, possibly can, about these individuals to figure out what were the gaps. What are the things that can be addressed to prevent this from happening in the future? And these panels produce actionable recommendations that are then provided back to the community so that they can reduce the rate of opioid overdose. A second focus of the grant was to establish a community-wide collaborative. That's been done as well. Lori Juti from the Department of Public Health here in Cobb and Douglas counties, she's heading up the countywide task force. Sanjeta runs the local stakeholders meetings where we have many stakeholders from a lot of the agencies that were mentioned earlier by Assistant DA Pursley. The third arm of the work is investigations, and Aaron Bubens is the investigator. You're going to hear more from him later. The next grant, the one we just got, essentially is going to take that work and extend it and drive it into the community. There's a lot more focus on community involvement and community training, prevention efforts, and using peers to help persons with opioid use disorders address their disorder successfully by getting off their drugs. These are a little more details about those things I just mentioned, the 3 different things that have been done, and in terms of the results. In terms of the OFRs, the opioid fatality reviews, we've reviewed about 12 different cases in depth, producing over 50 actionable recommendations. The coalition meetings, the stakeholder meetings are held quarterly, and the countywide task force meetings are held, as well as subgroups, interest groups, specialty groups within that task force. And as far as the investigations, over 75 overdose deaths have been investigated, resulting in 25 active investigations, and Aaron's going to talk specifically more about the work that he's done in that area. So, what do we have? We've got a huge issue. Just think about Sanford Stadium in Athens and McCamish Pavilion in downtown Atlanta being full of people. We're losing that many people a year, plus 7,000 more. We've got a huge issue. There's 2 epidemics occurring simultaneously. Only one of them has the benefit of a huge international effort to address it. Only one of them has vaccines. We do have tools at our disposal to address the opioid use disorder individuals we're working with, but it's not this massive effort, massive worldwide effort. So we can do a great deal. And in fact, what we've got to do moving forward is continue to build this community-wide effort to address this issue. Because it's easy to say, oh, I don't know anybody that uses opioids, or that's not really my issue. But it is. It's all of our issues because it impacts this entire community. Thank you very much.
Thank you, Dr. Baldwin, for sharing such vital information regarding the fentanyl crisis. At this time, we will hear from overdose prevention and response specialist Lori Jody.
Hi, everyone. My name is Lori Jute. I am the overdose prevention and response specialist with Cobb and Douglas Public Health. And I'm just going to talk to you guys a little bit about what Cobb and Douglas is doing to address the opioid overdose problem in our county. First, as Dr. Baldwin mentioned, we're coordinating the Cobb Opioid Task Force. This task force is a multidisciplinary group of people who come together quarterly to talk about the opioid problem, to talk about the gaps that we see. We use OFR recommendations, and come up with our own gaps analysis type surveys to come up with gaps that we need to address. And we're also working to eliminate the duplication of efforts so that we're working as efficiently as possible. And we also want to be able to get this group together so that when we do end the opioid crisis, we're able to be flexible to address the next problem that will inevitably show up. Have hope. Just a few more things about the task force. These are our priority areas. For now, we're focusing on data surveillance and response, and I'm going to talk to you guys a little bit about what we do there in that area at Cobb and Douglas. But we're also focusing on prevention and awareness activities, collaboration of all the community partners and communication among them, treatment access and recovery, harm reduction, and law enforcement and judicial. So, as I was saying, one of the main focuses of my job is to do surveillance of overdoses in the county. And so surveillance is just keeping track of how many people are dying and how many people are going to the emergency room. And we do this to facilitate a rapid response to any clusters that may be found. Right now, we're working on what a response to clusters would look like, but for the most part, it does involve reaching out to our community partners and alerting them to the cluster so that they'll be aware of it in their parts of the community, and trying to just gather as much information about the cluster as possible, like what types of people it's affecting, what types of drugs, like say several young kids got a hold of Percocet or something. That would be something that we would want to let our partners know about. So that's what surveillance and response is for. And so this would be the process of a response. So we'll do active surveillance, such as using a system called ODMAP, which I will go over in a little bit, a little later. And also passive. Law enforcement will say, you know, we found this, and they'll let us know, or hospitals will say that we have seen a lot of overdoses lately, and they'll ask us to look into it for them. So the next step is investigation, and that mostly consists of me going through medical records. So I can see when the person had the overdose, and often, especially if they have a behavioral health assessment, we can find out information like who they were using with, what the pills may have looked like, whether or not they expected to have this reaction, and just other demographic information about them that might be useful. And at that point, we're able to notify our partner, engage our resources if we are able to at that time, and then hopefully have enough information to give law enforcement for identification and elimination of the source. That's the ultimate goal anyway. So ODMAP is the Overdose Detection Mapping Application Program. The data is populated mostly by first responders. It comes through the EMS system called Biospatial, but you can also add information to it. If you're on the law enforcement side, you can add it, and law enforcement actually overrides the EMS data. But I can also add information, so I add overdose deaths from the medical examiner. And what we're hoping to really use ODMAP for is for law enforcement and public health and other stakeholders to get a good picture of where these overdose clusters are happening in and around the community, so that we know where to target interventions. So ODMAP can help the community by identifying areas of increased overdoses, helping law enforcement in their pursuit of traffickers, providing data for predicting where clusters may occur, and you can also use it for grant proposals to get information for that stuff. I couldn't show you guys a picture of ODMAP. I'm sorry about that. We're not allowed to show the public the map, but it's got dots. It's pretty. So one example of an overdose surveillance and response, an activation is it started to show clusters in particular zip codes. It started in Augusta and Savannah is where they first really noticed it. And then they noticed that there were a lot of people that they thought were overdosing on fentanyl. So we started noticing this in Cobb County as well. After they sent out a statewide notice about, there might be fentanyl contaminating drugs, then we started paying more attention to it and noticing it also happening on our map in our zip codes. So we also initiated a response and started doing medical record reviews. And very fortunately for us, hospitals started conducting toxicology screenings for fentanyl in March, right when that may be why we noticed. They probably were having fentanyl overdoses well before that, but we started really noticing it in March because they started actually testing people who would come into the emergency room so that we could see that they had in fact overdosed on fentanyl. So from that time when we first started noticing fentanyl happening in March to when I last pulled the data in on September 9th, there were 96 ER visits for fentanyl overdose in our WellStar hospitals, because that's what I have access to. Now, this does not represent all of fentanyl overdoses in our county. As Mr. Adams will tell you later, there are many more overdoses that never make it to the hospital. They just refuse, transport or whatever. They get the naloxone, they feel better, they don't go to the hospital. But this, and we can't really tell right now if this is a lot because we've never seen fentanyl able to be confirmed before. But what's really concerning is that many of these people, 54 of them at least, did not know that they were taking fentanyl. They thought they were taking something like cocaine. Many of them thought that they were taking heroin, which is not as shocking that they ended up having fentanyl, but they didn't know that they were getting fentanyl. They didn't have the tolerance necessary to combat, the potency of the fentanyl because they were someone who just used cocaine or heroin on a normal basis. So what we did when we found all of these people who were overdosing on fentanyl is we went ahead and alerted the people in the law enforcement in those particular zip codes where we found clusters of them. And then we did some public health messaging. We did a bus shelter poster. Kennesaw State put up some banners. We also went through social media and traditional media to just put the word out that fentanyl is definitely here. It's definitely contaminating our street drugs. So these are the people that it has been affecting. If you know anything about the opioid overdose in any way, you'll see that it looks a lot like this. It's usually males who are affected, and it's also primarily in young to middle-aged people. So the 30 to 39-year-olds have the highest numbers, but it really is affecting 20 to 49-year-olds quite a bit. And here's a little map of where it happens. It happens all over Cobb County, but there are some zip codes where there seems to be a lot more people affected by this overdose problem. Just give you a second to look at that. And as we've found this really sad statistic that fentanyl has actually, in Georgia anyway, been really affecting our kids. So from 2019 to 2021, there was an 800% increase in overdoses from fentanyl in this age group. I looked at our Cobb County data. We had one under 19-year-old girl who died of, or I don't know if she died. I just know that she overdosed. Wait, she died. One overdose death of a kid. She actually was in Gwinnett when it happened. But it is here, it is affecting our kids. And I think from what I heard in a talk today, it's probably because of those pressed pills that Dr. Baldwin was talking about. Kids are more likely to take a pill from their friend that they don't really know where it came from, and that's probably why it's going up in kids. So I just wanted to go ahead and put a call to action out there for you guys, having known this information, what you should do about it. I mean, we've talked about what Cobb County is doing about it. what you can personally do about it is, one really important thing is to carry naloxone, even if you don't think you know anyone who has a problem with opioids. If you've ever been prescribed opioids, you should carry naloxone, because you see it all the time in the medical records that people are overdosing on their own medications. So you can get naloxone from the pharmacy. There's a standing order. You can buy it from your pharmacists. If you do know someone who is likely to overdose, you can get it for free from the Georgia Overdose Prevention Organization. And if you need more information about that, you can go to our website, and I'll have the information on how to get there on the last page. Don't trust any medication that you did not get directly from your pharmacist. A lot of people get stuff from their friends or neighbors. They don't know where their friends or neighbors got it from, and that often is one of the big problems of people who are overdosing on fentanyl with no tolerance to these kinds of drugs. So do talk to your kids about fentanyl. Like my nieces are 13 and 16, and they didn't know what opioids were, but they do know what pain pills are, and they could possibly get this from their friends. So that's something you really need to talk to your kids about, that if it didn't come from your doctor, you don't know what's in it. You can also learn more about the agencies that are working in this area from their websites, and find out the resources that we have here in Cobb County. Get involved in the task force if you'd like to, or other activities. And you can always find a way for your neighborhood or agency to support the prevention efforts. So this, if you ever want to talk about it more or have questions, here's my contact information. If you want to know how to get naloxone, we have information on our website. That's how you get to it. You click on emergency preparedness and then the opioid epidemic underneath that. We also have resources where you can go to get, we have like a page that'll just show you the different treatment providers, the different recovery organizations. We also talk about how to responsibly use opioids if you've been prescribed, how to dispose of them, that kind of thing. So yeah, if you have any questions, I guess we're holding them till the end. I'm done.
Thank you, Lori, for sharing such vital information in regards to the OD map and the opioid statistics. Now I'd like to welcome Division Chief Nick Adams.
Thank you, Sanjetta. Lori was talking about the OD map, which she said she couldn't show you, so I hope I don't get in trouble for this. This is actually the biospatial map, which is one of the data sources that Lori gets the information for our OD map to be able to kind of show what we're seeing out in the field. And one of those things, it's kind of the outline of Cobb County, it's not really there, but this is all the overdoses that Cobb County Fire and Emergency Services has seen year to date. This is just year to date. This also does not include Marietta Fire, Smyrna Fire, or Austell Fire. This is just Cobb County. And I don't know how well that slide is showing on your screen, but if you can see up at the very top there in what we call the Devil's Triangle, which is the area between 575, 75, and the Cherokee border, you can see year to date we've had 40 responses to overdoses just this year alone. Also down there in Mableton, in the far southern tip of the corner, you can see 22, and right in the middle in the Fair Oaks area is about 25. But one of the things I want you to do is kind of try to pick out your house on this map, and you'll notice that no neighborhood is untouched by this epidemic. So that's just kind of what we've done year to date. To put this in perspective a little bit, in the month of July in 2022, Cobb Fire and Emergency Services administered more Narcan than in the entire year of 2017. So in 1 month, we delivered more doses than during our peak of 2017. So that's kind of what we're seeing right now. We're seeing a lot of fentanyl and overdoses in our community. Lori was talking about some of the patients that we're seeing report to the ER. What we are seeing in the pre-hospital environment is that only a percentage of our patients are actually being delivered to the hospital. Most overdoses, once they call 911 and they get that administration of Narcan, they usually refuse services after that. 40% of our patients are refusing services and never going into the hospital system and never going into any other type of peer recovery center. So one of the initiatives that we are going to try to take on with a partnership through DPH is leave behind Narcan kits. Like I said earlier, 40% of people who have been deceased from an overdose has had at least one encounter with EMS in the prior year prior to their fatal overdose. We also saw that 10% of patients that we have administered naloxone to just die in the following year. So having the access to the ability to get these take home or leave behind Narcan kits. So basically our responders, once we give Narcan to a patient, if they refuse to continue their care and go to the hospital, we will leave behind a kit with either them or their friends and family that will have instructions on how to use the opioid, the Narcan kit, and also how to reach out for recovery peer counseling. One of the best practices that we're trying to do as an EMS system here in Cobb County is that leave behind naloxone. We found that if we left that leave behind naloxone kit, the patient had a 4 to 6 times better opportunity to get in touch with a peer coach or peer support. So one of the things we always talk about is we have a problem in front of us, and as responders, we like to do what? We like to fix that problem. So I want to talk about a couple initiatives that we have here in Cobb County where we are really leading the way nationwide. The first is our Cobb Fire Cares, our community assistance, referral, and education services. Because one of the things we discovered is that a lot of our community, the solutions they need is not a big red fire engine responding to their call or an ambulance or a police officer, especially those in our community who call 911 multiple times. We call them our loyalty members, if you will, is we are trying to find solutions on how to reduce call volume towards 911. And what we'd learned is about 40% of our recidivism or our repeat callers was based to some sort of behavioral health emergencies. So we have these, almost like these quick response vehicles. These are community paramedics who identify people who are using the 911 system excessively or quite a bit, and they will try to follow up those people. And they're almost like our first responder detectives, is a term I heard the other day, is they try to find out, well, why are these people calling 911, and what can we do to help them so that they can get the right services for whatever that need may be. When we initially started this program, we thought it was going to be mostly our senior citizens, our elderly who were trying to live in place, and we thought the solutions were going to be things like building ramps or installing grab bars in houses so that they don't fall. But like I said, we discovered 40% of our problem is people who are having some sort of behavioral emergency or is addicted to drugs or alcohol. In 2019, we were able to partner with the Zone for a quick pilot study. We would have peer coaches that will come with us, the paramedics, to go visit people that we had given Narcan to in the last 72 hours and give them the opportunity to meet with a peer coach and try to find a way into recovery. And that system, although it was a pilot, was very successful. Fortunately, we were kind of derailed by the pandemic. We haven't been able to continue that program, but we're looking to restart that program later this year. Let's see here. And this is kind of just what I just went over, is that we realized that things we could do kind of to prevent people from calling 911 in the first place was being very effective, and a lot of that was substance abuse. We also have the Partnership for Assistance, Treatment, and Health, and that's what we call our co-response unit. It's a combination of paramedics from Cobb County Fire and Emergency Services, police officers from Cobb County Police and some of our other municipal agencies, and mental health clinicians from Highland CSB, which has been a wonderful partner with us. This team will respond to people in crisis, and they also do follow-ups on people who either had a behavioral or substance abuse emergency. And that's what I got. Thank you very much. We'll hold questions to the end.
Thank you, Chief Adams, for sharing information regarding CARES and naloxone. Now I'd like to introduce myself. I'm Sanjetta Tiller, case manager for the Opioid Fatality Project with the Cobb District Attorney's Office. The Opioid Project is supported by a grant awarded by the Bureau of Justice Administration. Our objective is to combat the opioid epidemic in Cobb County through a multi-agency group of key stakeholders. Some of our objectives include to improve law enforcement responses to opioid-related investigation of dealers and distributors, to accurately report data on the opioid epidemic in Cobb County, and implementation of the Opioid Fatality Review Panel. So let's talk about that. What is the Opioid Fatality Review? The Opioid Fatality Review Panel meets on a bi-monthly basis to review a timeline of a decedent's life. The timeline consists of information such as demographics, if this person was ever incarcerated, if this person ever received substance abuse or mental health treatment, ever experienced a traumatic life event that led up to his or her death, just information to help understand the way this decedent lived their life. I received this information from the decedent's next of kin. The panel consists of various agencies, including representatives from the local hospitals, inpatient substance abuse treatments, the Department of Health, the medical examiners, the local law enforcement, and others. Some may ask, what is the importance of OFR reviews? The importance of the OFR reviews is to formulate recommendations of missed opportunities of a decedent's life. Some recommendations include providing crisis stabilization once a person has been released from the hospital who's been addicted to, who has an addiction disorder, conducting a preliminary assessment for no drug arrests, such as having a crisis team to respond to these calls instead of incarcerating them, depending on that nature of the call. Another recommendation is to provide Narcan to substance abuse inpatient treatment facilities and local hotels to reduce opioid fatalities. Due to the recent death report, fatal overdoses occur at local inpatient facilities and local motels in the Cobb area. Another recommendation is to provide Vivitrol shots prior to the release from jail. Vivitrol actually blocks the effects of opioids, such as heroin or opioid pain medications. But the overall recommendation is designed to combat the opioid epidemic from a community approach. After conducting numerous interviews with families, I've learned one word: compassion. I speak with families who are truly heartbroken. I speak with families who've done every single thing they could have possibly done to save their loved one's life. It's helpful and most appreciated that we make resources available, whether those resources are mental health, therapy treatment, providing a safe environment for grief families affected by the overdose death, or something as compassionate as opening your arms to a person with a substance use disorder. It is often encouraged to healthcare providers and public safety members to treat everyone with dignity and compassion as a first step. I will admit, most families display signs of denial. When a person passes away to an overdose, it is often compared to suicide. In most cases, individuals with an addiction disorder often increase the dose of their drug of choice as they become immune to the former dose that was used to get them high. An accidental overdose may also occur when a person with a substance use disorder restarts their drug addiction or restart their drug habit after sobriety or release from incarceration. There's also stigma behind drug overdoses, which includes labeling, stereotyping, and discrimination. It will be helpful to educate ourselves. Any efforts to address the drug overdose crisis must include action to reduce stigma. Let's watch a short video titled "Stop Stigma," save lives, preventing overdoses.
There's just a lot of stigma feeds into the prevention of people taking healthy steps to prevent overdose and to dealing with overdose when it happens.
For the overdose, I believe it may, because it's not going to stop. People are going to use. That's the way it is. Maybe if we had an injection site where there is a nurse, whatever, around, maybe that could help out. Maybe more of us having that Narcan kit.
That's what a lot of people think. If you're a heroin addict, every time you stick a needle in your arm, it's like playing Russian roulette. And a lot of people think of it as, oh, well, there's another guy. Just another junkie gone. OD. Don't worry about it, right? No one probably doesn't have family, probably doesn't have this. You know, who does he have, right? That's what most people think about a junkie when they find him dead.
I don't think people should be so hush-hush about it, you know. I think kids need to be taught at a very young age that this is very real. And, you know, compassion and caring and acceptance is what's going to help these people want to change. Mm-hmm. You know, if they don't have that, why are they going to get out of addiction?
I think if we can lessen discrimination, people will access services. There's a better chance that people won't have to die from overdoses. We're losing lots of community members. It doesn't have to happen. That's the biggest injustice of all.
Like, it terrifies me every time I hear the ambulance. It scares the hell out of me because I'm thinking it's someone I know.
Interesting video. After I meet with families, I do provide free of charge grief resources to help in the United States. I mail reading material to help the families understand the experience of a person with a substance use disorder. I also provide wraparound services for those who've been released from incarceration. We understand those released may need extra help with navigating into environments that may make it hard to find treatment and/or employment. Our office will also provide those leave-behind kits with Narcan and other supplies to help those in need. Thank you. Now I will turn the mic over to our next presenter, Investigator Boopins.
Good evening, everyone. I'm going to talk for a few minutes about the investigations that we're doing from the District Attorney's Office. We restarted investigations in late March of this year. There was a gap. The previous investigator was deployed, and we also had COVID issues that we were dealing with. So I picked up investigations in March. Just to give a little bit of background, kind of explain our scope, where these cases come from and how they're looked into. Primary methods that we receive cases, and when I say cases, I'm referring only to overdose deaths. I'm not actually referring to overdose cases that EMS responds to, just the deaths are what we're looking at right now. Most of our referrals are from the medical examiner's office. Notification is either made at the scene or once they identify what the cause of death was. We also get notifications from the police department. Some of the detectives will reach out on occasion. And then my own personal research, looking at calls for service, and we have other methods of referral. One category that I should add here is we've had a couple of cases that have come up from either district attorneys or other investigators that have cases that they're aware of, people that they've worked with that have submitted some cases for us to look at as well. So what are we looking at in the investigations? Primarily, we're looking at the police reports. We're going over the police reports and looking at all the information contained therein. As I'll speak about later, that's a little bit of an obstacle at times because a lot of times these are looked at as accidental deaths. So not always a lot of information in those. Our second basis of information we have is the autopsies, the investigator reports, the toxicology reports, all of those coming from the medical examiner's office. I conduct interviews with families, friends, witnesses, people who are at the scenes, sometimes suspects that were involved in the case. And then our primary source of information is cell phone extractions. Those first four things are our primary sources of information. As you can see, we have a couple different ways of getting those cell phone extractions. Secondary sources of information, we're looking at criminal histories for both the victim and for any suspects involved in the case. Then we're looking at records that we can find online, looking through social media profiles. We have a variety of law enforcement search tools that we can use, and then obviously open source documentation as well. From there, we're looking to develop a narcotics investigation that we can supplement the death investigation with. I try to work closely with MCS and the different CID units throughout the county to develop suspect information, provide them with information about where these drugs are coming from, who's providing them. We're running phone numbers, we're processing locations, we're sharing information just to try to develop narcotics investigations. I'll conduct surveillance on some of those locations that we develop. We're responding to crime scenes. And then crime lab testing is another area that we're hoping to develop. It's well behind schedule, as I'm sure everybody knows. But identifying the actual ingredients of an overdose kind of helps us narrow down. It goes back to the OD map and some of those different areas where we can kind of look at patterns as to how these opioids are being provided, where they're coming from, and why they're contributing to so many deaths. And then finally, we have intelligence that we develop from other sources. So of the cases that I've worked on so far since March of this year, there's about 77 of those cases. I know for a fact this is not all of the overdose cases throughout the county. This is just the ones that I've come across or the ones that have been sent to me. Here's a little chart just to kind of show you where those cases are coming from, who's supplying those cases. Obviously, Cobb County, CCPD is providing the majority of those cases, but Marietta, they've provided a lot of those cases as well. The two other cases actually came from hospitals. We had 2 cases that we identified patients that were transported to the hospital that ended up passing away. And we had to actually go back and request police reports be done for those deaths because they weren't caught, they weren't identified. And then the 3 unrelated, those ended up being cocaine overdoses, not opioid overdoses, but we still provided information to the police departments on the suspects where the narcotics came from. Austell PD, not to call anybody out, and KSU have not reported any incidents to us so far. Of the cases that we're talking about, the 77 cases there, looking at the drugs involved, I hope to, in future symposiums or future talks, to maybe kind of give a better idea of drug trends. But just for these cases in particular, and again, this is only cases that we actually have the autopsies or toxicology reports for. So it's not all of the cases that I referred to previously. But of the cases that we do have the toxicology reports for, the vast majority you can see is a combination of fentanyl and other drugs, albeit meth, cocaine, lots of different types of prescription medication. But the majority of those overdose deaths involve combination drugs. The second largest category is fentanyl only, and I'll talk about that in a second. Then we have the cases that we excluded, which were cocaine-based. And then the last category, which Dr. Baldwin referenced, is kind of a shrinking category, thankfully, is heroin and meth-related cases. Of those cases, looking at the categories of overdoses, just to kind of give you a perspective, broke them down into 3 categories, but we're looking at intravenous drug use or syringe use, people that are shooting versus people that are typically snorting. Of those cases referenced on the left there, 19 of those cases were intravenous use that we know of, that where there was a needle found either in the person's possession or in close proximity that had recently been used. And then 21 of those cases involved either pills crushed up or powder that was being ingested. 7 of those cases we don't know the method of how they ingested the narcotics. Either the scene was cleaned up or all the drugs were used during the overdose. Again, this is only limited to the cases that I have that have toxicology reports. It typically takes anywhere between 6 weeks to several months before I get those toxicology reports all the time to review them. And going back to the chart on the left there, the fentanyl cases where we know that fentanyl was the only drug found in their system, all of those cases involved the pressed prescription pills that Dr. Baldwin mentioned. Speaking on challenges that we face investigating these cases, one is just the sheer volume of the cases that come in. They typically come sporadically. Usually a bulk of them come in at once. As of right now, I'm the only one investigating those cases. So it can be a lot in terms of processing all the information, gathering all the reports and things that are necessary, and then looking into the cases. But primarily, there's no real statute. There's no guidelines that exist right now for me to use. There are other states that have those in place, but we're kind of starting from scratch, working backwards. It's a unique crime scene, which I'll talk about at the end. But one of the biggest challenges is that we don't always get the information right away. So a lot of these cases are identified much later than when they actually happen. Either there were no narcotics on scene for anyone to know what exactly happened. They're just going to a death investigation, and we're getting the reports after the fact. So some of these cases will appear months after they occurred, and now we have to go back and try to get the information from there. Our next biggest challenge is, to sum it up, it's really just kind of shifting a law enforcement perspective from responding to a medical call to now we're investigating a potential crime. And I've been guilty of this as well. So these calls come in as a variety of different types of calls for service. It might be, an assist other agency. It might be just a strictly like a medical call. It might be a death investigation. It might be a person down. So officers are showing up on scene, as I'm sure the chief can speak to. A lot of times they're there for scene security. Either the person is already deceased or they're being worked on by EMS and they're going to be transported. So a lot of times in terms of the officers arriving on the scene, maybe it's a scene that they've been to multiple times, sometimes multiple times in the same night. But shifting their focus from, hey, this is just another medical call, to this could potentially become a crime scene, and now I need to make sure that I'm securing the evidence on scene, I'm getting the names of everyone involved, I'm trying to get possession of the narcotics that are on scene so that we can test them, so we can find out what's in those narcotics, and making sure that we seize those cell phones so that we can use them for our investigation later sometimes is a challenge. As I mentioned before, it's a unique crime scene. It's not something that most officers are used to. They're not used to responding to this kind of call and looking at it from this light. We have to work on shifting their focus to make sure that they're looking at the potential evidence that could be there at that scene so that we can actually investigate these cases and move forward with them. A lot of times the people that they encounter at those scenes aren't always willing to provide information. They're going through emotional issues at that time. They might be intoxicated themselves. And a lot of the times the people that are there with them have ingested the same materials, so they might get transported as well, just to kind of give you an idea of what some of the challenges that we face. The last category that I would talk about is, I mentioned the cell phone extractions that we do. While those are extremely helpful, There's a ton of information on people's cell phones nowadays, location data, all those different things, but those investigations are extremely time consuming. They take a lot of time to actually go through that material. You need to have a certain kind of computer hardware in order to process those extractions. They take a long time to download. And then we're responsible for storing that information, and it just takes up a lot of space. So those are some of the challenges that we go through when we're investigating these cases. And moving on to end on a good note here, just to talk about some of the progress that we've made so far this year. First and foremost, we've gotten the investigation back up, which might sound like a small feat, but it has not been a small feat. Going out and meeting with all the different police departments, all the different agencies, letting them know that we're back up and running, meeting the people who are in those positions now, getting our face out there, letting them know that we're going to take these cases, we're looking for information, we're looking to push them and investigate where the narcotics came from. It's taken a lot of time, but we're moving forward now. We've seized a lot of different cell phones, as I mentioned. Sometimes those come in on consent. Sometimes those come in after the fact, where families are providing those because they're happy that someone is looking into the case. So we've had so many different cell phones that we've started going through that now the DA's office, we're trying to develop a digital crime lab where we can actually process those full time and go through the information so that we can use it for investigations. As Ms. Tiller mentioned, we do a lot of interviews with family and friends. Most of the police reports that we get are very straightforward, so there's not always a lot of information, and we have to kind of build a picture of who this person was. So we do a lot of interviews with family members and friends, associates, and all those interviews that we're doing, either Ms. Tiller will participate or will refer them to the services that we have vetted through the DA's office to kind of make sure that we're connecting people to the services that are going to help them in the future. And then, as she mentioned, also we have the leave behind kits that we're producing, that we're going to start leaving with those family members. So far, through the cases that we've worked, there have been a total of 5 arrests that we've made based on information that's come through the overdose cases. Again, I'll mention that there are no statutes currently, so we're using whatever methods we can to develop a narcotics investigation to make an arrest. I still have warrants pending in several cases that we're coordinating with MCS, but we're moving forward the best we can. The best kind of cases that we can create have a twofold investigation, one involving the actual death investigation and one involving a narcotics investigation that we try to blend together to bring a twofold case in terms of making a case on the suspects involved. And lastly, not only have we made the arrests, we've also developed information from these investigations that we've passed on to other police departments in other counties to help with their investigations going forward. So we have several investigations going on in several other counties as well. Thank you for your time.
Thank you, Investigator Billings, for such detailed information in regards to the Cobb opioid investigations. At this time, I'd like to welcome Program Director Daniel Spinney.
Thank you. As it says, my name is Daniel Spinney. I'm the Program Director at Davis Direction Foundation, the Zone. And I'm going to go over some of the services that we offer at the Zone, helping with this epidemic. Ooh. There we go. So Davis Direction Foundation, the Zone, is an extension, Zone is an extension of the Davis Direction Foundation, a nonprofit corporation that is led and governed by the people of recovery family. The Zone is a recovery support organization that mobilizes resources within and outside of the recovery community. The Zone provides many free services and supports, which I'll be going over, that makes it possible for people seeking recovery to gain peer connection and knowledge and skills necessary for them to establish and maintain long-term recovery substance use disorder. Some of the things that we offer is for personalized support. I kind of categorized all these. So personalized support, we have nationally designated recovery coaches. At this time, we have 4. By the end of next month, we should have a total of 7. We also mental health coaching. We have just recently added that. We have 8 mental health coaches that are available right now. Our 8 certified mental health first aiders. We have individual peer support, individualized peer recovery plans. We also offer 12-step sponsor list. We have an emotional support dog that works 9 to 6 every day. We have 36-hour rooms during the holidays. As we know, these are crucial times for addicts, so we are open 36 hours straight for Thanksgiving, New Year's, and Christmas. We have peer connections, 32 different recovery meetings each week. There are multiple pathways in recovery, and we have multiple pathway meetings each week, such as AA, All Recovery, CMA, NA, Dharma, SMART, CM, MA, HA, and we're also, HA is coming, yes, sorry. Some essential services that we offer. We do feed 3 meals a day for people that are in recovery. We require that they sign in. We serve breakfast. After the noon meeting, we serve a hot lunch. And then after the 4 o'clock meeting, we give them meal tickets. They have to attend the meetings, and they were able to get meals. We do pantry bags, hygiene bags. We have a barber that comes every Monday. We have shower service now. We have a laundry service that will be returning. I just got the notification actually today that it will be returning next week. We have clothing vouchers, transportation assistance for essential services. We have a computer lab. We do homeless outreach. We try to go out once a week and do that, and we offer resource packets and some housing assistance as well, to sober livings and stuff like that. Health and wellness. We have mental health support groups, recovery support meetings, experiential learning groups, mindfulness and meditation meetings. We have chiropractic service. We have master certified trainer and nutritionist that comes once a week. We have a full gym, 36-hour rooms, as I mentioned before, and during the holiday, prayer breakfast. We have free COVID testing. We also offer free Narcan and fentanyl test strips as well. So if someone is in need of those, they can stop by. We'll give you a brief training, and you have to. Then we can receive some free Narcan. Education. We have the Cobb House, which is the Cobb Overdose Prevention Education House. This is a trailer that is set up as a child's room. We do tours of it to the parents to help them look for signs. We show them places like where kids might be hiding drugs, signs to look for in their children's house and bedrooms to look for. Community partnerships, we have many of those. The Zone magazine is digital and print format. Like I said, we do naloxone training. We do individualized recovery plans. We have Beyond the End Zone prevention event. C-Car recovery coach training. I am one of the recovery coach trainers. We have a class coming up next month that is full. We have 16 that will be going through that class. Adult mental health first aid training. Like I said, we just have all the staff go through it. We have 8 of them now on staff at the Zone. We have the Zone for Reentry program and the Zone for Youth Reentry program. So we are working with adults as well as juveniles, trying to get them adapted to go back out into the, be a functioning member of society. The Zone is located at 32 North Fairground Street in Marietta. That is my email. You can contact me about any of the free services or any of the other services that we have. And that's the phone number to the front desk. And please stop by anytime. Thank you.
Thank you, Daniel, for informing us on the great programs and opportunities at the Zone. Just a friendly reminder, we will entertain all questions at the very end of the presentation. If you would like an index card to provide us with a question, please feel free to raise your hands and someone will provide you with the card. We will now hear from the Donor, Develop, and Fundraiser Coordinator, Sarah Mango.
Thank you, Sanjetta. Well, my name is Sarah. I'm a person in long-term recovery, and tonight I'd love to tell you my story. It actually begins when I was 7, and all I could see was blood. I was in a horrible car accident with my family, and you know the metal headrests on the seats in the car? I was sitting in the middle and I pushed my sister back and my face actually hit it. It severed my nose from my face. I had a hole from here to here. I had to have like 4 or 5 surgeries to actually repair my face. Luckily, I had a good reconstructive surgeon, thankfully. But in school, it was very difficult for me. I got bullied a lot. I got called Scarface, ugly, mangled face, you name it. And my mom would try to like build my self-esteem and put me through like cheerleading, modeling, all these things. And at the end of the day, to cope with that, I chose drugs. I could have chosen something healthier to cope with it, but I went into my mom's medicine cabinet, and what started with Xanax and Soma turned into meth and heroin. So by 18, I was doing cocaine and heroin. I shot up for the first time at 20. And then for about 10 years of my life when I was bartending, what I would do is I would get up in the morning, I would do some meth, do some heroin, go to the bar, bartend all day, drink all day, then get off work and get more meth and more heroin. And that was my day-to-day life for a decade. I kept getting arrested. I think I've been arrested like 9 times or something like that. It was always for like petty crimes. So my family would always bond me out of jail. I never had to actually like deal with being in jail for a long period of time because I would just get out and get high again until I got put in Cobb County Drug Court. Eventually my crimes became so high risk that I was facing felony charges. And thankfully that's where I got put because it actually saved my life along with the zone. So in drug court, if you get caught using or you break one of the rules, you actually go to jail and you don't get bond. So you actually have to sit in there. And on one of my sanctions, I was in there for 111 days, I'll never forget it, and I was an inmate worker. And this really, really nice lady came to visit the inmate workers, and she told me about the zone. So when I got out, I knew I had to go to recovery meetings anyway. I'm probably gonna have community service, so I might as well try it. It's the first place I went. And I had never felt accepted in my life until I went to the zone. People didn't judge me. I felt like I could be myself. I always had to lie and hide my drug use from my family and everybody else around me. And so I started out doing community service. I actually got hired as a janitor and worked my way up. I graduated Cobb County Drug Court. I became the program director of the zone. Through the zone, I actually got educational opportunities. I got a CAC, which is Certified Addiction Counselor credential, and a CADC, which is a Certified Alcohol and Drug Counselor credential. She put me through grant writing school. Anything I've wanted to do, Missy and the zone have always, always supported me, and I'm just grateful for them, so thank you.
Thank you, Sarah, for sharing such heartfelt testimony. For closing remarks, we will hear from Senator Kay Kirkpatrick.
Thank you very much. Can you guys hear me in the back? Okay. I'm going to shift gears a little bit. I've been asked to cover a couple different things. And before I start that, I want to just tell you about 2 books that I read that I think really encapsulate this problem. They're both written by the same guy, Sam Quinones. One of them's Dreamland, and it really gives a great perspective on the opioid issue. And the second one is called The Least of Us, which is more about fentanyl and meth. And I would highly recommend that if you really want to understand this, that you take advantage of those books. I just got an alert last week. I'm in the state senate, and I serve Cobb County, which is a blessing. And I'm really proud of the work that's being done in our county. And I really think that this is a great program, and I want to thank the DA's office and all the people who participated in this. I think we can do a lot more than we're doing, but this is a great program to get the word out. I got an email from the Department of Public Health epidemiology section that was an alert about all the teenage overdose deaths that we've been seeing. And there's a spike. It's a massive crisis that is different than what we've been seeing before, as I think you can tell from some of the information. But what I wanted to mention to you all is there are a couple things that are related, but a little bit different. One is the opioid settlement money, and I want to give you the latest on how that's going to work. This is a work in progress, but there are going to be 2 parts to it. And this is a massive amount of money, and I think it's going to work better than the tobacco settlement that we had before, because that money went into the general fund. This money is specifically going to be directed to 9 different things, and they're all related to either treatment or prevention, and they're very specific. And I have a list here if anybody wants to see it later. But there's going to be a statewide advisory council. First, there has to be a trustee who's going to manage, be in charge of keeping track of all of this. There will be a statewide advisory council appointed by the governor. That has not happened yet. There's no trustee yet, and there's no statewide council yet. But there's also going to be, and they're going to rely heavily on regional advisory councils. And these are based on, 6 of them are the regions by the Department of Behavioral Health and Disabilities, Developmental Disabilities. We call it DBHDD because nobody wants to say all that. But there are 6 regions, so that's 6 of the regional councils, and then there are 5 additional ones for municipalities or counties that have a population over 400,000. So that includes Cobb, DeKalb, Fulton, Gwinnett, and the city of Atlanta. So each of them is going to have a regional advisory council. Those will be appointed by the local governments. And so y'all need to keep track of that, because that's going to be very important that we get the right people on those advisory councils to make decisions about these grants. Because what will happen is there will be applications for the grants, and then the regional councils will make the decisions about who's getting the grants. And of course, because it's there are a lot of strings that will be attached, so we need to be sure that those grants perform the way that they're supposed to perform. So stay tuned on that. That's about all the information I have about it right now, but I'm happy to have people contact me if you want more information. As I get it, I'm happy to share. The second thing I wanted to mention that's, again, sort of peripherally related is the new suicide hotline, and that is the 988 number. That rolled out July 16th, and the crisis line number that we had before, the GCALS number, is rolling into the 988 number. And since July, there has been an increase in the number of calls. I don't think the word is out yet, but the same people that were answering the calls on the former crisis line are the same people answering the calls on the 988 crisis line. And interestingly, because our state really has done a pretty good job of preparing and planning for that, the preliminary report that we had on a webinar last week is that those calls are being answered in an average of 7.4 seconds. And that's really important and pretty impressive for this early stage of the game, I would say. I've got the PowerPoint with me that they gave us in this webinar a couple weeks ago. If anybody wants more information about that, I'm happy to share it. But that relates because many times people who are in crisis, they may or may not be contemplating suicide, but they may call that number. And a lot of times the intervention is the call. So in other words, a lot of people just need someone to talk to. But then some people may get referred. There may be a mobile crisis unit that's called, and they may end up being in a treatment situation, or they may not. So it's all very new, and we're going to have to follow the data on that. But what I was really asked to talk about, since I've used up, I think we're a little ahead of schedule, because I think I've already used up most of my time. Is that okay? Okay. It's House Bill 1013, and that is a game-changing bill that we passed this year. And the other bill that I'll just touch on is the fentanyl test strip bill, which legalizes that, and I think that's going to help us too. But the mental health bill was a huge bill. It's 76 pages long. I did not bring that one with me, but I'll send it to anybody who wants to read the whole bill. It's divided up into sections, and it was a very fascinating political story of how it went, but I won't get into all that. You just need to know that at the end of the day, after all the pushing and pulling, it passed unanimously in the Senate and the House. And it's in effect. The governor signed it the day that we passed it. There are 6 sections. The first section has to do with something called parity. And parity means that if an insurance company covers mental health, substance use is included in the mental health definition. then they have to treat it the same way as the way they would cover a physical illness like an appendectomy or a fractured wrist or something like that. And there's already federal law about that, but we didn't have any way in Georgia, since we knew that law was not always being followed, to hold anybody accountable for that. So now our insurance commissioner, Commissioner King, has guidelines. There's enforcement tools, there's teeth in the law to help make sure that that happens. The second section, which I think is actually very important, is the workforce section. Because what we know, or what we think we know, is that we don't have enough providers for mental health services, substance use treatment services all around the state, especially in the rural areas, but even in the urban areas. We can identify people, but then what do we do with them? So Section 2 does two things. One, it creates a service cancelable loan program so that if you are in school to become a licensed professional counselor or something like that, you can get a loan, and if you serve in that area, I think it goes up to 3 years. It's a year for year that it cancels the loan. So in other words, if you're there for a year, the loan is canceled the payback is canceled for a year. So that's going to be helpful, but I also really like the database that we created for the behavioral health providers, because right now I'm a doctor, I'm an orthopedic surgeon, and when I renew my license, I have to fill out a bunch of questions that say, how many hours a week do you work? Do you take Medicaid? Are you going to retire in the next 5 years? Where do you practice? Et cetera, et cetera. And mental health providers, other than physicians, have never had to do any of that when they renew their license. Well, now they'll get the same questionnaire to fill out when they renew, and then we're going to have a better idea who we've got around the state, because we really have no clue. You have to understand the problem before you can move to fix it, and so I really like that part of the bill. The third part creates a grant program through the DBHDD for assisted outpatient treatment, and one of you I think you referred to the loyalty program that you have. Sometimes some people refer to that as frequent flyers, and it basically means people who utilize services a lot and they cycle in and out and they never get anywhere, they never get what they need for treatment, they're just in the system going around and around. And so assisted outpatient treatment allows intervention early in the process for those people without an inpatient commitment. So this is a grant program, and it'll be handled through DBHDD, and it does not change the criteria for inpatient commitment. The other thing it does that's really important for our law enforcement community is it authorizes law enforcement officers, if they encounter someone in a crisis, whether they're high or whether they're about to jump off a bridge or whatever, to call a doctor at an emergency receiving facility and get approval to transport that person without arresting them. So if no crime has been committed, they've still got a way now to take that person to get an evaluation, and law enforcement will transport them there. So we know that jail is not necessarily the best option for a lot of folks. So law enforcement community likes that, and the other part of that for law enforcement is these co-responder teams, and you guys already talked about that. There are 5 of those programs in the state of Georgia now: Savannah, Marietta, Cobb. I don't remember where the other 2 are, but this creates a grant program so that the other counties that are a little bit less well-resourced than our county can create these programs. And so that way, if a patrol officer is out there, everybody's got CIT training. It's mandated in law enforcement, but that doesn't make you a psychologist necessarily or a mental health professional. And so this gives you a phone a friend, a backup, so you can call a behavioral health provider that is part of your team and get them out there. And that will help the decision-making process and hopefully present some of the really bad outcomes that we've seen previously. The fourth section creates a grant program for accountability courts. I won't spend a lot of time on that because we've got a great accountability court system in Cobb that we are so proud of, and we're cutting edge on that as well as many other things. But some of the counties that are smaller, less population, less tax base, don't have those set up, and this allows them to apply for grants to do that. And then it also addresses the cost of transport, because once a law enforcement officer takes someone to a facility for an evaluation, they can't just stay there and wait and see what happens. And so it covers how that's handled. I don't remember the details, but it's addressed in the bill. The fifth section has to do with kids and adolescents. And one of the things we have in state government many times is that we don't have good communication between the agencies that are working on the same exact thing, but there's not a regular channel of communication, and so things can fall through the cracks. So this resurrects a program that used to exist. Nobody's really sure what happened to it, called match teams. And this is for, again, kids and adolescents that are frequent flyers, that are regular users of services, and they're not getting anywhere. And this gets everyone in the room who can make decisions and turn that around. And then the last thing, oh, and before I leave that, there's now a new office in the governor's office. It's called the Office of Health Strategy and Innovation. No, Office of Health Strategy and Coordination. And the coordination part is the really important part, because that's what I was referring to about the communication between the agencies. This way, all the agencies report up to that office about what they're doing on the mental health front, and that includes substance use issues. The last section, the sixth section, is very important from a workforce standpoint, and that is a mandated rate study by the Department of Community Health every 4 years on how providers are being reimbursed. Because we know that Medicaid, for sure, and a lot of other state programs, the reimbursement for mental health is not necessarily where it needs to be to attract people to that field and get people to want to participate. And so this requires that we find out where we are and that we keep track of that as the years go forward. It also delays the sunset of the Behavioral Health Innovation Commission, sorry about all the long names, which was supposed to sunset next year, and it's extended now until 2025. And they are meeting, their task forces are all meeting regularly, and I'm sure there'll be more bills to come that will address what we're working on. And then the other thing that happens in that section is there are certain medications that might be really helpful that currently have not been covered under Medicaid. For example, there's an injectable drug, I can't remember the name of it, for schizophrenia that lasts for a month. And so you can just imagine if somebody who's schizophrenic and they decide they don't want to take their meds or manic depressive or whatever the problem is, then this kind of takes that decision away. And those drugs are expensive. And there will be other ones that will come out. But that may be a way to help some of the folks that are getting off track with their medication use. So this bill is not everything to everybody. There was a lot of negotiation and changes to the bill, but I do think it's going to make a difference for our state, and that's about it. So I'm accessible and easy to reach. My Senate email, you can go to the Senate website and find me on there. It's k.kirkpatrick@senate.ga.gov, and if anybody wants a business card or whatever, I've got them over here. So thanks very much, and thanks to the sponsors for putting this on.
Thank you, Senator Kirkpatrick. So now it is time for questions. If you have provided a question on an index card, we will answer those. If you need an index card, please raise your hand and someone will get you one. And I will direct these questions to the appropriate persons on the panel. The first question asks, what gaps has been addressed? I can answer that. Most of the gaps that have been addressed is providing Narcan kits. That was one of the recommendations. That's how we know what gaps to fill. And other gaps that has been filled is being able to provide resources and treatment in our communities. And that's why we have representatives here from inpatient treatment facilities. The next question asks, what is a cluster? And I think Lori mentioned clusters in the OD map.
So yeah, a cluster is just a group of people who have overdosed. So more than 3 in one area would be defined as a cluster. And an area is whatever you want to define that as. You know, it could be a zip code, it could be a town. It just depends on what the stakeholder who is interested in it wants to define it as, honestly.
Thank you, Lori. I think this next question would be for Erin. This question asks, what is a soft hand or a handoff?
Who asked the question? Yeah.
Oh,
I'm
sorry.
gonna
I thought
pass.
that was like an investigative, like police question. Like, what's the handoff? I'm like, is that drug related?
Yeah. Okay. Yeah, for sure.
Thank you, Daniel.
So a warm hand handoff, as we refer to it, is when we have reached our potential as helping a client and we know in which direction to hand them off to. So like if it was mental health, we'd reach out to Highland River Stabilization Unit. We could get them to a stable point at some point of our level, but once they reach beyond our level of care, then we reach out to our resources and hand them off.
And you can keep that mic really quickly, please. The next question asks, what is the process or procedure for MAT care? And I'm assuming that's the medicated assistant treatment. Or
What is the process or procedure?
Yes, it says process, procedure for MAT care.
Yeah, it'd have to be a doctor prescribed to get an MAT, which, you know, most doctors will prescribe them after doing evaluation. The one that we recommend is Dr. Sanders over at About You Family Medicine. That's who we use as a resource. He will sit there, he'll do an evaluation, he'll prescribe the MAT. Write the prescription, they will go get the prescription. Then he comes back to their office, takes the first injection or pill, whatever it may be, and then the client stays there for an evaluation and make sure they don't have any side effects to do it.
And also to follow up with Daniel, we do have treatment brochures in the back on the outside when you come in. There are treatment brochures there. Free of charge, you can take as many as you like, and they do have facilities in the brochure that can lead you to more facilities to go to for MAT care. So the next question asks, is MAT an option while in custody? Is there anyone here from the jail? So just to kind of answer that, based on our OFR reviews, the jail do not offer an MAT program at this time. And if they do, I think they redirect you to an outside provider for that type of treatment. The next question states, I've heard that opioids actually have a chemical biological change to a body enhancing addiction. Please describe. Opioids actually have a chemical biological change to a body enhancing addiction. Dr. Baldwin?
They're doctor now.
Yeah, not that kind of doctor.
Yeah.
Thank you.
Yeah, we do have a medical doctor here, Dr. Kirkpatrick. Yeah, opioids act on a system that takes advantage of a system that we already have. We have natural endorphins in our body, and opioids address the same sorts of needs that endorphins do. So endorphins make us feel good. You get endorphins. Endorphins act when you've experienced a pleasurable meal or sex or all sorts of things. So an opioid acts on those things. It is a physical property of your body. It works in your brain. It works in the rest of your body. It doesn't actually change the physical appearance of your body, though. However, long-term addiction might. So for instance, if you use any drug for a long period of time, it has certain effects on your body. For instance, it causes cardiovascular issues. It can result in, for meth, loss of your teeth, all sorts of things like that. So I'm not aware of, and I'll let Dr. Kirkpatrick address this, I'm not aware of any particular physiological change that an opioid has other than what I've mentioned. Dr. Kirkpatrick, anything addition to that?
I mean, the physiology of addiction is similar with all substances that people get addicted to, but that's not my area of specialty. But if you break something, I can help you.
I just want to say that if you're really interested in this topic, Dr. Nora Volkov, V-O-L-K-O-V, K-O-W, at NIH, she has a lot of presentations on YouTube about the physical happenings when you're addicted to opioids.
She's the director of NIH.
Yeah.
The next question asks, describe the migration from prescription to heroin to fentanyl. Describe the migration from prescription to heroin to fentanyl.
Sure, that's a great question. And one of the books that Dr. Kirkpatrick mentioned, Dreamland, is all about that. It's a fascinating book. It's written by a very skilled investigative reporter. But essentially what happened is that a number of years ago, drug manufacturers figured out how to make a better version of opioid pain relievers, and they marketed the heck out of them. And they became among the very most prescribed drugs in the country. And in a particular part of the country, they were prescribed and overprescribed extraordinarily often. And these opioid pain relievers, OPRs, have the same addictive potential as heroin or as fentanyl because they're all opioids and our body responds to them in the same way, whether it's an opioid pain reliever like OxyContin, oxycodone, Percocet, anything like that, or heroin or fentanyl. The body doesn't know the difference because they act on the same receptors in the brain. So what happened is that people all over the country, but in particular in the Rust Belt, where there was a loss of jobs in the coal industry, in the manufacturing industry, people all over the country, but in particular that area, started being overprescribed these pills. And then they would become addicted to them. And then they needed more and more, which resulted in doctor shopping. It resulted in pill mills, which essentially are doctors who were engaging in unethical and dangerous practices of overprescribing. There were a bunch of these in Florida, Kentucky, all over the country. Well, then what happened is that the Congress passed a law which resulted in what are called prescription drug monitoring programs, or PDMPs. Every state but Missouri. Why Missouri? I don't know. Every state but Missouri has a prescription drug monitoring program. What that meant is that every doctor, whenever they prescribed an opioid, they had to enter it into an online system. Every prescriber, every pharmacist, every pharmacy, when they filled the prescription, they had to enter it into the online system. And this made it much easier to track who was being prescribed and who was filling those prescriptions. It made it much more difficult to get those kind of drugs. In came the heroin market, led by Mexican drug cartels. Essentially, they, like good businessmen tend to do, businessmen and women, they see an opportunity in the market and they flood a market. So what happened is with the difficult time getting hold of opioid pain relievers, heroin rushed into the market. Heroin was so much cheaper. A dose of heroin was $8. An oxycodone pill was $80. So you get 10 doses of heroin for the same price as a single dose of oxycodone. So heroin flooded the market, and we then had a heroin problem. Well, then we started having a fentanyl problem because even though heroin's cheap, fentanyl is cheaper. Even though heroin is widely available, heroin depends in part, because it's a semi-synthetic opioid, on opium poppies in order to make it. Fentanyl doesn't. Fentanyl is a fully synthetic opioid. It's manufactured in the lab, and it's being manufactured illicitly south of the border and in China, and it makes its way over here. And as I indicated earlier, it only takes a little tiny bit. Dr. Nora Volkov, essentially has indicated that it takes 2 milligrams of fentanyl, which is about the size of 3 or 4 grains of salt, to kill somebody that doesn't have tolerance built up. So that's how it's happened. There's a very powerful graphic. I didn't show it here, but essentially it shows the 3 waves of the opioid epidemic. The first wave was the opioid pain relievers. The second wave was heroin. The third wave is synthetic opioids, in particular fentanyl.
Thank you, Dr. Baldwin. Maybe you can answer the next one. How does Vivitrol work?
I'm not a medical doctor, so I'm not going to talk about how it works in particular, but Vivitrol is one of a number of medications that fall under the rubric of medication-assisted treatment. And essentially what it does is it blocks the opioid receptors in your brain so that when you take an opioid, it doesn't have the same effect, and therefore it doesn't have the reward pathway that it would normally have because it's being blocked from impacting those receptors. So we have Vivitrol and a few others. Probably the one that most folks are familiar with is methadone, right? Methadone's been around since the 50s, right? Methadone is the original, the OG opioid antagonist. But we've got Vivitrol and a number of others. They fall under the rubric of medication-assisted treatment.
Thank you. Next question. When it comes to a lack of investigators, what is the cause? Lack of funding?
Great question. I would say that's a big part of it, yes, but I couldn't answer specifically. I know that, as I mentioned, not to beat a dead horse, but there are other states that have statutes specifically related to opioid-related deaths. So it's not necessarily put on, say, an investigator like it would be investigated by a task force or someone else. I think the best investigations are handled from, a department level through a task force. They're more complete. There's more access to resources and information. So it's part of it.
And next question. Can you require Austell and KSU report their overdose data?
I can ask. I've asked already. I've reached out. I've personally handed them business cards. I'm not sure why we're not getting that information. I can continue to push the buttons and ask the questions, but it's up to them. Other than finding the cases on our own through OD map or researching the cases ourselves, I don't have access to their reporting systems, but other than finding the cases on our own, that's all we can do.
So just coincidentally, they have their recovery breakfast out there a week from Friday at 7:30 a.m. And so I'm sure you could get some answers there.
Last question. Does the county plan to consider implementing safe use sites where medical professionals are on hand to help people using opioids take drugs safely? Does the county plan to consider implementing safe use sites where medical professionals are on hand?
A commissioner type question, but I know that no, not at the moment. The most that we're considering would be syringe exchange programs. We're in talks with agencies about how we might be able to do that, but there's no thoughts on safe injection sites at the moment, no.
Thank you. Any additional questions I may have missed? That concludes our symposium. On behalf of the Cobb District Attorney's Office, we would like to thank each and everyone for coming out tonight, for your time. We have provided a goodie bag for everyone to take on your way out. Thank you again, and have a great night.